really a pleasure to be here. I'm going to try to cover, when I was given the title, it was a little worrisome when you're given a title, Breakthroughs. And seriously, had I had this title about 4 or 5 years ago, I might have been a little hesitant to give the talk. But I really honestly believe we're on the verge of some breakthroughs, and I'm going to try to convince you of that. But I wanted to begin by asking a question. How many people here have donated money to the National Pain Research Foundation or to the American Pain Foundation? Yeah, and the reason why you haven't donated is because they don't exist. There are none. There are some small pain research foundations, but there's nothing equivalent to American Heart, there's nothing equivalent to American Cancer Society. And the reason is, in general, you don't die of pain. Unfortunately, you may die in pain. And so typically people give money towards the disease, the disease that killed the individual, but there's no input to give money to pain research. And for that reason, it's really important that I'm here. Because if you look at where the money comes from to do pain research, and one can argue as to whether there's enough being given, and I would argue obviously that there isn't. This is an interesting slide that illustrates the amount of money. This is just NIH, and there are other federal agencies, DOD, VA, that do support some pain research, but most of it comes from the NIH. And what you can see is, what's plotted here very nicely, is this is back in 2012. This is the expenditures in billions of dollars, and this is the societal impact in billions of dollars. And what you can see is there's maybe $250 million given in 2012 towards pain research, and yet the societal impact is about $650 billion, far exceeding that of almost all other major diseases combined. But the research funding, it's almost all coming from the federal government. Of course, pharma supports it, but they have a different agenda. And so I think what I'm going to try to convince you is that there have been breakthroughs, but surprisingly with what I believe is a need for much more funding, and the breakthroughs will come through a lot faster. So I'll do a little teaching just to bring everybody up to speed. You'd think that pain is real simple to explain. This is a typical textbook, and most people who teach medical students or dentistry students would say this. This is how pain works. So you have a pain fiber, what's called a nociceptor, and it gets activated by an injury. The input goes into the spinal cord, goes up to the brain, and poof, you get pain. Anatomically, this is correct, but it's actually pretty irrelevant and can't account for what the major pain problems are. It's much more complicated. So I'm going to give you a little primer, first on acute pain, and then move into the different types of chronic pain, and then try to identify where the breakthroughs are coming from. So we have an individual who picks up a hot cup. And if you look at its peripheral nerves, they're made up of different types of nerve fibers. You've got the myelinated, fast-conducting fibers that respond to touch. And then you have the unmyelinated or pain fibers. Excuse me. These are the fibers that will carry the pain message, and when they're activated, you will get pain. It's very simple, it seems. So here's an acute drawing. This is the textbook view. You have an injury. It activates a nerve fiber in your skin or in muscles or in joints. It goes into the spinal cord, up to the brain, and gets pain. If this were all that existed, all you had to do was cut it. And surgeons for years have been trying to cut nerve fibers to block pain, but it's not like the old telephones. It doesn't work that way. So let's look at a more contemporary view of what the pain fiber actually looks like. And this has really been a molecular revolution. The pain fiber is not homogeneous, and what we now know is that there are multiple types of pain fibers that are unique. They have their own molecular specificity, and what makes them very special is that we now know that there are different types of fibers for different types of pain, and then depending on the type of pain a patient might report, you will then try to develop a drug that treats that specifically. For example, there are particular fibers that respond to heat, painful heat. And it turns out the molecular entity that responds, that drives heat pain, is the same entity that responds to the allergenic substance in hot peppers, capsaicin. You have a hot pepper, you like spicy food, you like jalapenos. It works by binding that same channel that heat activates. Well, if a patient comes in with hypersensitivity to heat, that's the channel you want to go after. You don't want to just block everything. There's others that respond to acid, because when you have inflammation, the pH of your tissue drops, an acid starts to activate the fibers. That's what you want to block. And most interestingly, recently, there's two channels described, given the name Piezo. These are mechanically sensitive channels. Why are they important? Well, the fact is the major and probably the predominant pain problem, postoperatively particularly, is movement-associated pain. If any of you have had surgery and you get off the table, it hurts to move. Or if you've exercised too much, or you break a limb, or you hurt your muscles, it hurts to move, probably because you're activating these channels. Follows that if you can develop a drug, and that's what pharma is trying to do, against these channels, you can selectively treat the problem of mechanical hypersensitivity without eliminating the pain problem. That's the last thing, all pain experience. And the last one, which you may not think is that important, is a cold channel. And why is a cold channel important? Because it turns out there's many people, particularly who are taking chemotherapy drugs for cancer, who develop an unbelievable cold hypersensitivity to the point where they stop taking the drugs. The side effects of the drugs are so severe, they say, I'll deal with it. I can't handle the cold hypersensitivity. So this is the new way of looking at the pain fiber. But there's another really exciting aspect of the pain fiber that we now know, and that has to do with the possibility that we're on the verge of development of much more specific and useful local anesthetics. How do local anesthetics normally work? It's pretty straightforward. Everyone's been to a dentist and you've had an injection of a local anesthetic. Well, here's your normal pain fiber providing the input to the brain. You get a pain experience. You inject a local anesthetic, and what it does is it blocks the channels that allow for the electrical impulse to be conducted, the voltage-gated sodium channels that are absolutely required for the nerve to function. They work incredibly well. Local anesthetics will absolutely block pain. The dentist who sticks a needle in your jaw and anesthetizes it, you won't feel pain. You'll be numb. You'll also might bite your tongue because it eliminates all sensation. And if it gets into the bloodstream, as it will do if too much is given, it can produce seizures. It can stop your heart. In other words, it can have miserable side effects. And one of the reasons is there's not just one target of a local anesthetic. There are at least 9 different subtypes of that channel. Well, the exciting breakthrough is the recognition now that there is one particular subtype that is pretty unique to the pain fiber. Local anesthetic blocks everything and has side effects, but the new target is something called NAV for sodium, V for voltage, the NAV 1.7. So there's 9 subtypes. This is number 7. The numbers really don't matter. But what's so special about NAV 1.7 is that it's highly enriched in the pain fiber, and in fact it's not even found anywhere else in the brain. What that means is if you can develop a drug that targets that channel, you should be able to selectively block pain without affecting anything else in the brain because there's no target. So what's the likelihood that that can be done? And what's so special about NAV 1.7? What do we know about it that makes us think it's so important? Well, the gene was isolated initially in a family in Pakistan. And one of the first things that was identified is that there's conditions in which the gene is actually overactive. And when it's overactive, you get a condition that is a miserable condition called peripheral neuralgia. This is what a patient with peripheral neuralgia has. Hot red feet, hot red hands, and excruciating pain that's extremely difficult to treat. This is when there's too much NAV 1.7. The most dramatic result, however, is when there's not enough NAV 1.7 or when it's inactive. And there are people around the world who have a loss of function mutation of NAV 1.7. And there was a wonderful story in the New York Times Sunday magazine that talked about congenital insensitivity to pain. Now here's a woman who has no pain at all. She can feel heat, she can feel warmth, she can feel cold, but it never hurts. She breaks a bone or she has an injury internally, she'll never know it. That's not a good condition. Acute pain serves a purpose. It's chronic pain that's the problem. You can't read this, but it basically says she wishes she could experience pain. So here you have a case, if you have a gene where the pain cannot be experienced, what it suggests to pharma, of course, is if you could develop a drug that selectively targets this channel, and that's what every major drug company is working on, and their success is on the way, you should be able to develop it. And I'll just give you, can it be selectively blocked? Well, there are trials for a condition called trigeminal neuralgia, which some people have called the suicide pain. Maybe 2% of people with this condition will literally kill themselves because the pain is so severe. You may be familiar with this image of the scream. It's thought that he was actually trying to represent an individual with trigeminal neuralgia. This is definitely an individual with trigeminal neuralgia. Well, there are trials now, and they're looking pretty good, that an NaV 1.7 selective blocker can in fact eliminate this pain. I think, would you like to keep going? All right, will do. So this is on the horizon. Every big pharma is going after it. Let's keep our fingers crossed. So that's kind of an acute pain condition, acute pain target that we hope will be useful in chronic pain. But let's now talk a little bit more about chronic pain. And there's two major types. Chronic pain caused by tissue injury. We've all experienced it. You break a bone, you stretch a muscle too much, you overexercise, you fall, and you have pain, and it doesn't resolve. Arthritis is the most common. Here's a severe condition of arthritis. Now you look at it and it's an emotive picture. Oh, it looks terrible. Well, the patient will not tell you, oh, you got to straighten my fingers out. That's not the problem. They know that their fingers are distorted. The joints are destroyed. The problem is they can't tie their shoelace without pain. They can't type. They can't use their fingers because they have ongoing pain. And the worst thing is they have incredible hypersensitivity. This is the major problem that these individuals have, is that innocuous stimuli produce pain. Pain is not just produced by painful stimuli. It's when pain is produced by innocuous stimuli that people's lives are ruined. So how does that come about? Well, let's have a little primer now on chronic pain. Back to our nerve fibers. We're looking at the cross-section of the different types of nerve fibers in the arm, and I highlighted before the unmyelinated or slowly conducting pain fibers that in normal individual, they only respond to a painful stimulus. But in the setting of tissue injury, they now start to respond to normally non-painful stimuli. Light touch. Take a warm bath and suddenly it's painful. Move and it's suddenly painful. It's the same fibers that normally would not respond, now respond. So the fact is we know a lot about how this comes about. How is it that in the setting of tissue injury with inflammation, that a normal pain fiber now starts to respond to an innocuous stimulus? How is it that non-painful stimuli now start to hurt? And here's a simple example. You apply a heat stimulus to the arm, and now you plot pain. And you find that, remarkably, the pain threshold for pretty much everybody in this room is pretty identical. It's around 45 degrees centigrade. You will start to say it's starting to hurt. And as you increase the temperature, it hurts more. Totally normal pain. Now do the same thing in the setting of a little bit of inflammation. Apply the stimulus in the setting of inflammation, and all of a sudden you start to respond at 41 degrees and say it hurts. That's normally bath water. Shouldn't hurt. You have what's called, the term we call allodynia, or pain produced by an innocuous stimulus. And it's through a process we call peripheral sensitization, where the peripheral nerve fiber is now sensitized and starting to respond to mechanical stimuli that are normal, temperatures that are normal, or even a cool stimulus that is ordinarily normal. And it produces ongoing severe pain. And the way it comes about, and you've had it all, and in fact I would venture to guess that all of you have tried to treat it, sometimes successfully. Let's see how. So here's our friend again, and he has an injury to his hand he burned his hand from the hot cup. He has tissue injury. That tissue injury produces a lot of inflammation, and it produces a compound. The names aren't important. I tell it to the medical students, they forget it, so you can forget it too. Arachidonic acid. It's a membrane lipid. It's synthesized. But that arachidonic acid is then acted on by a very famous enzyme called the cyclooxygenase, or the COX enzyme. That COX enzyme produces another molecule called prostaglandins, and it's that molecule that's key, because what it does is it then acts right on that pain fiber and results in a lowering of its threshold. So now that pain fiber, instead of just responding to a painful stimulus, will now respond to a non-painful stimulus. And it's very likely that back pain, knee pain, hip pain, neck pain, headache pains are to a great extent resulting from this process. How do you treat it? Well, you treat it by blocking this enzyme, and you do it all the time. Aspirin, ibuprofen, naproxen, the so-called NSAIDs, non-steroidal anti-inflammatory drugs, they block the COX enzyme, and in fact, they relieve the pain. Unfortunately, they have side effects, and they don't always work. But they're effective, and that's how they work. But here's the breakthrough. We know now that it's not only prostaglandins that are made in the setting of inflammation. That's not the only enzyme that's turned on. When you have an arthritic joint, that joint has a slew of new cells that come into the joint, and it starts to synthesize a bunch of miserable molecules, some of which presumably are trying to repair the joint, but others are spitting out a lot of molecules, changing the milieu, the biochemistry of the joint, and they're all contributing to that sensitization process. And I want to highlight just one particular compound that comes out, one of the growth factors. These are peptides or proteins that are involved in the growth of cells, the growth of nerves, and the one that is most relevant to this discussion today is a molecule called nerve growth factor. Originally described over 100 years ago, or no, I shouldn't say that, maybe 50 years ago, by Rita Levi-Montalcini, who actually won a Nobel Prize for its discovery. It's involved in development of nerves in the embryo, in the fetus, and early postnatal. We don't really know what it does in the adult, but it turns out that if you can eliminate the nerve growth factor in the region of the joint, you can actually have a dramatic effect on osteoarthritis and other pains. So the way that's done is antibodies are generated against the nerve growth factor. You create the antibodies, they will work in humans. The antibodies then go around the bloodstream, get into the tissue, and they literally sop up all of the nerve growth factor that's causing the problem. And what's the result? Well, the result is absolutely dramatic. And every pharma is now all over it. The FDA had initially, there was exciting results. The FDA put a hold on it because there was a concern about a particular side effect. We can talk about it later. That hold has been released. Just one former result, this in 2010, but there are many since. This was in a New England journal. The name of the antibody is called, this particular one, tanezumab. I love the names. Ab just refers to antibody. But I want to show you, I wasn't going to plan to show slides of data. This isn't my data at all. But I want you to look at this. What they're plotting, these are patients with knee osteoarthritis, severe pain that's debilitating, quality of life is ruined, they can't get around, they can't work, they're constantly in trouble, and then they're given antibodies to nerve growth factor. 2 shots, one at the beginning of the experiment, of the trial, and then second a few weeks later. Excuse me. On the left is pain score, and what I want to point out is the result after 16 weeks. That's 4 months, 2 injections, and we're looking at the results 4 months later. This is the placebo. The reason why pain trials are so difficult is that placebos work. Doesn't mean you don't have pain. Placebos work. Pain is a perception in the brain. My wife is not convinced that it's not in her hand. I keep telling her it's in your brain. She's convinced now. But anyway, placebos work because psychological factors will influence the pain experience. But here you got about 20% reduction of pain in osteoarthritis at 16 weeks after placebo injection, but a 50% after 2 injections of the antibody. And this will keep on going. So here you have the opportunity to treat what is probably the major clinical pain condition that Americans are experiencing. Back pain, knee pain, osteoarthritis. Anybody gets older is going to get it. Hip pain. Yes, you can have surgical procedures, and sometimes they work. But this is the treatment, by the way, that is usually patients are getting narcotics for. Non-cancer, non-post-op pain, this is what narcotics are for, are being used for. This is on the horizon, and we're excited about it. Are these, in fact, breakthroughs relevant to the opioid epidemic? I didn't think I could come to this group and not mention the opioid. In fact, I cut my teeth originally studying narcotics. Well, the fact is that morphine and other opioids, OxyContin, you name it, are still the most powerful drugs for treating severe pain. That's a sad thing to say, but it's the truth. And they're very effective for postoperative pain, and they're absolutely essential for cancer pain patients, especially a cancer pain patient who is terminal. I mean, that is the best way to treat that individual. You want to get rid of their pain. The real question is, what do you do for all the other types of pain that will go on for years? Well, we know that it'll be helpful for some patients, but there are adverse side effects that are the big problem. The adverse side effects: psychological dependence, misuse, respiratory depression, and death. Because the receptor that the opiates target is found all over the body. It's not just found in pain-relevant areas. The reason why someone takes heroin is not to get pain relief. They want to get a high because areas of the brain involved in reward have the same target. So the hope is that maybe we can develop, a drug that will target the opiate receptor that's more relevant to the pain pathways rather than the reward pathways. That's one direction. The alternative, of course, is develop drugs that will treat osteoarthritis, which is the main reason these patients are being given narcotics. And if you can get rid of that pain without having to use narcotics, you're going to make a huge impact on the opioid crisis in this country and anywhere else. Just a brief word on migraine. Does anybody in the audience have migraine? Yeah. Well, it turns out 17% of women and 6% of men. This is huge numbers, and in many cases it's debilitating. Obviously people, they can't work, they have to go into a dark room. So migraine, there are drugs around, they have side effects. Big problem for people who have severe migraine. It's hugely debilitating. Well, on the horizon, and very near horizon, is a breakthrough. A breakthrough not only for pain management of migraine, because most of the existing drugs for migraine will stop the headache, but they won't prevent it. There are patients who are walking around with getting 10, 15 migraines a month, and you can't prevent it. All you can do is stop it when it happens. The new treatment is another antibody approach, and its target is a peptide, and we don't have to go into the details, CGRP, calcitonin gene-related peptide. But it's on the horizon, and I'll give you a brief 1-minute explanation of how it works, because it's pretty exciting. Here you have a brain, and the brain is invested on its surface with blood vessels that are in the dura, the covering of the brain. Here are the vessels. Well, what happens when the vessels dilate, that triggers the migraines. We know that. And now we know that the molecule that triggers the dilation, that triggers the headache, is CGRP, calcitonin gene-related peptide. So, and this is all happening outside the central nervous system, not inside, it's on the outside. So antibodies have now been developed, and just the way the other antibodies sop up the nerve growth factor for osteoarthritis pain, here the antibodies sop up the CGRP. They can't get into the brain, so they don't have side effects. The antibodies are big. Antibodies to CGRP eliminate the CGRP. The vessels don't dilate. Headache gone. Again, not only headache gone, but it's preventive because these antibodies last for months. That's the remarkable thing. You tell a patient that not only do I have something that's going to block your pain, but it's going to prevent you from getting 10 to 15 headaches a month, some of which are going to keep you at home for 2-3 days, that's a breakthrough. And this is on the horizon, and it's a near horizon. Several companies, again, have the antibodies. I don't really care who comes first, but these are close. Just a little quick, if you want to read something, I can get you references, but I just found this is a recent review of all the anti-CGRP studies, and this was one statement from it. The results so far are extraordinarily promising. A turning point for prevention of migraine. Those are pretty powerful words, and it almost literally gives me the shivers because I don't have migraine, but I know plenty of people who do. Now, I'm going to end by talking about neuropathic pain, which is a major, major problem. So this is pain caused by nerve damage. That's nerve damage in the periphery, your peripheral nerves, or it could even be nerve damage in the brain, post-stroke. Patients with multiple sclerosis, people don't realize that many of them have pain. People don't realize that when you see somebody in a wheelchair, you say, oh, they're paralyzed. Well, 70% of them have uncontrolled pain. You don't know it until you ask them because you can't see it. So nerve damage-produced pain is a huge problem. Here's one, complex regional pain syndrome. Little mild injury to the foot. This person has ongoing burning pain, hypersensitivity. You can see the foot's red, it's distorted. Big problem, hard to treat. Postherpetic neuralgia. Everyone knows what shingles is, the herpes virus. It lasts about 8 weeks. It's painful. It usually recovers. In about 20% of people, doesn't recover. And you're left with postherpetic neuralgia. The lightest touch to the forehead of this woman produces excruciating pain. Got to do something about it. I was editor-in-chief of Pain. You got to pick the covers, the only good thing about being an editor-in-chief. This was a sculptor who was illustrating. He had complex regional pain syndrome. This is a sculpture. He's trying to illustrate, this is what I experience. You can't see it. You can't feel it. Pain is difficult. It's subjective. This is what he experiences all the time. So there are many ways to try to treat neuropathic pain, and I won't explain how all of them work, but here's from the periphery up to the brain. You can use gabapentinoids, which are the drug of choice. That's what a patient will be put on first. But then there's local anesthetics, there's nerve blocks, there's spinal cord stimulation, there's a question about cannabinoids. I said spinal cord stimulation, there's other antidepressant drugs, there's brain stimulation, and of course there's complementary medical approaches. So there's so many things that can be used to try to treat these conditions. What's the problem? The problem is that they are, at best, 30% effective in 30% of patients. They work, but that means 70% of patients are not getting any relief, and of those who get relief, it's minimal. We need something better. And what I want to end on is just to give you a different perspective to approaching this problem. Something we're doing in our group and other groups are picking up on now. It's a rather radical approach, but I think it's a perspective on the problem of pain that I think is worth discussing. So the usual approach to treating nerve damage-produced pain is pretty straightforward. Nerve damage produces neuropathic pain. So what you try to do then is you block the pain and treat it as a symptom of the herpes infection, of multiple sclerosis, of a stroke. Pain is a symptom and you want to eliminate the symptom. But apparently it's not very effective. So the alternative that I'm going to try to introduce to you is novel treatment is to treat the pain as a disease of the nervous system. A disease of the nervous system, because the nervous system is completely altered in the setting of this damage. And if you could repair the disease, repair the damage, eliminate the disease, and then the pain should go away. That's the logic. I'm going to try to convince you that it actually works. So this is a simple diagram, highly simplistic as what is going on, and it's a lot like epilepsy. Everyone understands epilepsy. Patients has a seizure. Why? Because they've lost inhibition in the brain, and they get hyperexcitable brain, and they have a seizure. And how do you treat it? You treat it with anticonvulsants to try to shut down the seizure, bring back the inhibition. Think of neuropathic pain as similar. So this is a spinal cord. Here is our pain fiber, famous pain fiber, comes into the spinal cord and it sends the message to the brain. I showed you that before. I threw in 2 little yellow cells, inhibitory cells, because they're there and normally they keep things quiet. When you have nerve damage, you can actually lose those cells. When you lose those cells, you got pain. You got ongoing burning pain, you got hypersensitivity. How do you treat it? Looks like epilepsy, except it's in the spinal cord. Well, give an anticonvulsant, and that's the treatment of choice. Not that effective, but that's the best we have. And the hope is the pain goes away. Well, what about the possibility of treating the disease, in other words, repairing the damage to the nervous system? You lost those inhibitory neurons, maybe you can put them back. Sounds radical, but that's what we're doing. So transplant, precursors, cell transplants that will make these cells and repair the damage. It all started back with my recognition with colleagues who have studied, and this is what basic science is all about. Here's someone, a psychiatrist, who's studying the development of the cortex. He wants to know what nerve cells in the cortex, where they derive from. Nothing to do with pain, not even to do with epilepsy. He's just a basic scientist who happens to be a shrink. And what he identified, this is John Rubinstein, that this is the mouse, but it's the same in humans, there's a region called, the name's not important, medial ganglionic eminence. That's the origin of all the inhibitory cells in the brain. Cool observation. What does it mean? Well, what they did is they said, what if we took these cells from a mouse that's green through a genetic trick, and we transplanted them into a mouse that has seizures? These are inhibitory cells. The inhibitory cells will grow when they transplanted them. They spread all over the place. And what they found was they could treat the seizures. They reduced the seizures in this mouse that had a defect that gave it a high propensity for seizures. Well, I saw this and I went to John. I said, John, I think neuropathic pain is just like epilepsy in many ways. Do you think we could treat this condition with the transplant? And he said, I said, do you think we could try it, actually? And he said, you can try anything, Alan. I don't think it's going to work for several reasons. Number one, you want to put it in an adult. They had at that time only did it in postnatal animals, so we don't know if it'll survive. The other thing, you want to put it in the spinal cord. These are destined to work in the brain. It's the wrong environment. They probably won't survive. I said, that's encouraging. And then the other thing is, even if they do survive, it's like an ET come home condition. These cells want to go back where they came from, and chances are you put them in the spinal cord and they'll end up back in the brain. You know, with that encouragement, we of course decided what makes science so much fun is that you try things that everyone says won't work, at least sometimes. So Joel Braz in my lab tried it. Make a long story short, it works. I won't go through all the details. I'll briefly summarize it just to illustrate. Can these cortical cells that belong in the cortex from an embryo transplanted into the spinal cord actually survive? Well, here's the model. So here's our spinal cord. It's a big blow up. And we have our pain fiber coming in. And then I've said, well, when you damage them, the inhibitory interneurons, the blue cells here illustrated, many of them will die. That's the model. And then what we do is we just transplant about 50,000 of these cells taken from an embryonic brain. And the question is, will they survive and grow? Well, this is what it looks like when you transplant, they're green because they have a reporter, into the brain one day after. You get a little plug of cells. You just sort of sit there. And then you come back a month later, and they've now started to move. But they don't go back to the brain. They don't even go to the other side of the spinal cord. They stay where we want them to stay. And if you look at a single cell, this is what it'll look like. They grow. They are happy. They put out processes, and we've shown that they make synapses. They're functional. They do everything we want. The key question, of course, is, so what? Can they actually treat the hypersensitivity that characterizes neuropathic pain conditions? And there are many models that we use. I'll give you one data slide to illustrate a result. We have a model of complex regional pain syndrome. Minor little nerve injury produces hypersensitivity. Well, we do the same thing in a mouse. You cut 2 of the 3 branches of the sciatic nerve, and you find that the animal becomes hypersensitive to a mechanical stimulus, just like a human. So here's the result. We're plotting, if you will, pain on the left side. That's not what we're plotting. It's a reflex. We injure the animals, and then you find that their threshold, it's not pain, it's their threshold for responding to a stimulus, is very low, has dropped. They're hypersensitive just like the human. Then we transplant, and then you follow the animals out over time. It's all done blind, and you break the code at the end. When we come back 4 weeks later, the animals that were transplanted are now normalized. And we've repeated this many times, and it has been repeated by other groups now. So we conclude, if you treat it as a disease to eliminate, not a symptom, that you can actually have a dramatic effect on this condition. And we've now followed the animals out for 6 months. It's not a pump where we're just spitting out this inhibitory molecule. It's actually rebuilding the circuit and normalizing, if you will, the problem, treating the disease. Now here, I love this. Where do we go from here? Well, my daughter, I live in San Francisco, so my daughter happened to live next to a psychic, and she sent me this. So, psychic fair was canceled at this place. Why was it canceled? Due to unforeseen circumstances. So I'm not a psychic either, but I'll just tell you, we are now treating other conditions. We are treating chronic itch conditions that result from this, and we have started using embryonic stem cells from humans. And I will say this, I'm actually on the scientific advisory board, I've got to be honest. There is a company that developed, I have nothing to do with the company, that is trying to bring this initially to treat epilepsy, and my hope is that it'll eventually try to treat pain. But we have now transplanted human cells into the spinal cord that have been modified to become these inhibitory interneurons, and they're effective. Not as effective as the mouse-on-mouse transplants, but we think that more studies can actually make them as effective. And with that, I will end with one important slide, this one. So I talk about pain, but I keep talking about sensitivity and hypersensitivity. But as I mentioned, pain, it's in the brain. The bane of pain is plainly in the brain, is what I tell the students. That it's complex, there's a sensory component, but there's also an emotional component. If there's no emotional component, there is no pain, it's just sensation. So understanding the complexity of the pain experience requires a lot more, and imaging studies are providing insights. I show you this because it was one of my favorite covers. This was a painting by a patient who had a stroke, severe post-stroke pain. But what she described is when she painted this particular painting with a red background, she had no pain at all, no problem. But if she tried to paint it with a blue background, she had excruciating pain in her painting arm. So it was like putting her hand in a freezer. Now this woman does not have a mental problem. This is the complexity of the experience, that the environment in which she's even living in is influencing your experience. We need to understand that, and we need to use approaches to treat it, in addition to the things I told you. But I do believe we're on the verge of breakthroughs, and I really look forward to the next couple of years. And I should end by telling you that at least the work that I reported, the last bit on my lab, wasn't done by me, but Joao Braz, who did the transplants, Alex, who did a lot of physiology, a postdoc and a student, Dina, who just got her PhD, did a lot of the behavior, colleagues in McGill and in Australia who did some of this work, and we continue. Thank you for your attention.